I think we're going to get started. Thank you so much for coming. It's so exciting to see a full room. My name is Maureen Perry-Jenkins, and I'm the director of the Center for Research on Families. And for those of you who don't know, actually I see a lot of students in the room too, so click on our webpage. We're an interdisciplinary center that supports faculty and student research on issues broadly related to families, and as you'll see, today's talk and the kind of research that we present all year long covers everything from individual and cell research all the way up to economic and social research, because families are in the sort of center of all that. So that's our mission, that's our goal. We fund student research, we fund faculty retreats to work on their own research and undergraduate work, so take a look. And I know that today I was told by my associate director that I have to say this, there's a lot of journalism students here who are working on science writing, and we are going to be looking for science writers at the center. So write your best paper, and you might have a job. One of the wonderful things that the center does is has a scholars program, and that scholars program, 6 to 7 scholars join together from all different disciplines to spend a year working on a grant. And because of the money we have from an endowment from Dorothy Gavin, called the Ty Gavin Erickson Endowment Fund, each scholar gets to bring in a person to help them really dig into their research. So the scholars write a grant, or a draft of a grant, share it with someone that they want to invite. Today we have Antonia Calafat, and they spend the day talking about their research and how to make it better, and then we get to have a public lecture at the same time. So it's a win-win for everybody, and it's really very exciting. So I first just want to introduce our scholar today, Dr. Katherine Reeves, who is assistant professor and program head in the Department of Epidemiology in the School of Public Health. And Katherine's been working this past semester and this semester on a grant that she's working on that you're going to be hearing about pretty soon. But her research focuses on modifiable risk factors for breast cancer with the ultimate goal of reducing breast cancer morbidity and mortality. And her research focuses on modifiable pathways that mediate breast cancer risk through hormonal pathways, including depression and our antidepressant use, obesity, and metabolic disease. She's actually working on a grant this semester. We're learning a lot about soup, because she's looking at BPA in soup cans. There's going to be some pilot work going on, so anybody who wants to participate, you should talk to Katherine. But the title of her grant application is The Effect of BPA Exposure on Serum Estrogenic Activity in Healthy Women. And she's applying to the National Institute of Environment Health Science to evaluate women exposed to BPA in their diet, if they exhibit increased estrogenic activity in their bodies as a result. And we believe these effects would have important implications for promoting breast cancer research and outcomes. So Reeves' intended benefit of this research is to promote the health of American families, American women, all of who are exposed to environmental chemicals, and many of whom are touched by breast cancer. So I'm going to introduce Katherine Reeves now, who will then introduce our speaker for today. Katherine?
Thank you, Maureen. It's been a pleasure to be part of the Family Research Scholars Program, and really wonderful to have the opportunity to bring in a mentor today, and certainly an honor to introduce you to Dr. Antonia Calafat. Dr. Calafat is the chief of the Organic Analytical Toxicology branch at the Division of Laboratory Sciences, National Center for Environmental Health of the U.S. Centers for Disease Control and Prevention in Atlanta. She earned her bachelor, master's, and doctoral degrees in chemistry from the University of the Balearic Islands in Spain, and prior to her career at the CDC, she was a Fulbright Scholar and a research associate at Emory University. Dr. Calafat currently is leading the CDC's biomonitoring programs for assessing human exposure to a wide variety of chemicals found in consumer products and our environment, such as pesticides, phenols, and phthalates, among others. Her collaborations are numerous and highly multidisciplinary, including work in the fields of epidemiology, toxicology, exposure science, and also health assessment. And these active research collaborations have led to a very impressive list of over 200 published manuscripts, including a paper on population exposure to BPA that was honored by the journal Environmental Health Perspectives as the 2012 Classic Paper of the Year. So to say that Dr. Calafat is an expert in her field is truly an understatement. Her work in exposure assessment really is the gold standard by which others are measured. And speaking from personal experience, when you write in your grant application that the Calafat Laboratory is performing your measurements, not one reviewer questions their validity, but rather it's uniformly regarded as an important strength of your research. And the importance of her work to accurately measure human exposure to environmental chemicals really cannot be overstated. Understanding whether such chemicals represent a hazard to our health starts with a precise assessment of our exposure. And this work has important implications for policy, public health, and of course the well-being of our families. It truly has been a pleasure to have the opportunity to work with her in person today and to benefit from her extensive expertise. Dr. Calafat, thank you so much for leaving sunny Atlanta only to come up here to the snow. We very much have enjoyed your visit, and we're looking forward to your talk on biomonitoring chemical exposures in human health.
Thank you, Katherine. This was really one of the nicest introductions I ever had, and it's really, I'm here speaking for the work that many have been doing, and it's really an honor to be in representing the work that we're doing at CDC. I hope I'll give you today a little flavor of what is we can do in public health and what a chemist, I'm a chemist by training, can do to just improve the health of all of us. This is just a brief outline of my presentation. I'm just going to give you just some general considerations about what is biomonitoring and what I think is very important looking at the interpretation of biomonitoring data. I'm going to be looking at talking about NHANES. It's a national survey that we conduct at CDC, and then giving some examples that we have obtained on our work with NHANES on environmental chemicals, many of them with have endocrine disrupting capabilities. NHANES is a fantastic tool, but is not the answer to everything. So we like to work with others in different studies that may give me answers to just the questions that NHANES is not going to be able to address. And then I'm going to give you with some final thoughts. We are exposed to chemicals. The food we eat, the water we drink, the air we breathe. And some of these chemicals may be harmful. But it's important to remember that human health is something like multifactorial. So it's going to be dependent, the influence of a chemical on health is going to be depending on some intrinsic susceptibility, like on your genes. It's something that you're born with. It's also going to be dependent on the environment. And then I'm going to be talking today mainly about chemical exposures, but don't forget that we're also having the non-chemical stressors that may be as important. Lifestyle and nutrition are certainly very important as well. And last but not least is the time of when the exposure happens, the duration of this exposure, and the intensity of the exposure. So you may be exposed to a certain chemical at one time in life, and it's not going to do anything to you. But that same exposure in another time of development, for example, may have a critical effect. So we are exposed to chemicals, but then how are we exposed to chemicals? And I like to think that it's a complex scenario, and then that the control conditions that many times happen in animal studies do not certainly apply in humans. We are exposed to many and numerous routes and sources, when in animal studies it tends to be only one particular route of administration. Many times you don't know, in humans, certainly the dose, the duration, and the timing of the exposure, when it's something that you have a little bit more control in animal studies. And I like to think, some people say you're exposed to soups. Maybe I'm more of a party person. I like to think we're exposed to cocktails of chemicals. So we're exposed to multiple chemicals, and then with all this mess, how are we going to assess exposure? And there is really not one approach, not one size fits all. So I'd like to think that we have different approaches to assess exposure, some of them being like general epi, type of research, looking at questionnaire and historical information, environmental monitoring, like you may want to look at the chemicals in the environment and see what these chemicals, like the levels of these chemicals are trying to make up, how much of the chemical is getting into you. You can use personal monitoring, hand wipes are certainly very good examples, or personal samplers, maybe, if it's something related to breathing, and chemicals that are present in air. And the tool that is dearest to my heart, and the one that I would like to try to get you acquainted with, if you haven't been already, is biomonitoring. But I just want to emphasize that biomonitoring is one of the approaches, is not the answer of everything. And the best answer to your research question is you're going to have it when you are able to integrate the different approaches and then into sometimes in models that then they can give you an idea of what is really this true exposure scenario. Biomonitoring, this is one of the definitions of biomonitoring, is the assessment of internal dose by measuring the parent chemical or the metabolites in human samples. Mainly we use blood and urine, although you can use pretty much everything, it's just that with caveats, I would say. If you don't remember anything about my talk today and you want to know something important about biomonitoring, just remember that integrates all the sources and routes of exposure. That's why it's important that you have other information. When you have a urine sample and I give you a concentration, I cannot tell you whether it came from what you ate today, from the product that you use, or from, whatever, like the things that you have been touching. It also is important to remember that biomonitoring, you're looking at trace concentrations, very low levels, much lower than the levels you're going to find of the particular chemical in the environment. And also it's very important to remember that we measure concentrations, we do not measure exposures, although we use those concentrations to categorize exposures. Biomonitoring is certainly not new. In the late 19th century, then it was used in pharmaceutical applications, just looking in the urine at salicylic uric acid, at the levels of people who had rheumatic people that they were taking a precursor of aspirin. It was also used in the late 1900s, 1800s in occupational applications to look at workers and determine whether in the blood, whether they had been exposed to lead. We know that lead poisoning is something that is not really good and is preventable actually. So we have gone a long way from the late 1800s into now, and biomonitoring is incredibly sophisticated. So for biomonitoring, you need one of the first things that you need is just having something to quantify. You need the standards. And most of the cases, those standards are not widely available, so they're going to have to be custom synthesized. You also need some standard reference materials that then to check the accuracy of your methods. You need the state-of-the-art instrumentation, and this is why, remember, you're looking at trace levels, very low levels. So the instruments that you have to be able to just detect very minute amounts of a particular chemical, sometimes in a very small amount of sample. We may talk about a few drops, like a teaspoonful or something very little. And this instrumentation has to provide adequate selectivity, which I think is as important as sensitivity. Like you have to be able to say for certain that what you're measuring is chemical A, and not something that behaves like chemical A. And this is not as much in the detection part, but is in the preparation part, in the separation. You're looking at this very small amount of a chemical in a matrix complex, like blood or urine that has a lot of stuff. And you need to make sure that what you're saying is chemical A and not something else that was in the matrix. That may be that for this reason you may have to have clean rooms, like the one, this is Emily Edenfield, one of our chemists, and then this is actually for the work that they're doing with PBDEs. Some PBDEs are in dust, so we cannot do the sample preparation anywhere. We had to build these specific clean rooms so we could process the samples. We rely heavily on automation, and then we can improve reproducibility and throughput. And we need very highly trained staff. With all of this, I don't think it's any surprise that I'm coming down to my last point, cost. It is expensive. It's not cheap because it requires a lot of stuff. And I'm a chemist by training, but so you certainly need to have a very strong chemistry foundation in biomonitoring, but there is more than only chemistry. And I just is what I call an analyte that you measure in analytical chemistry versus a biomarker that you will measure in biomonitoring. Again, this is what you would require for the method that I spoke about, so there's no need to go into this. But these are some of the things that the considerations that are really very important if you want to develop a truly good biomonitoring measurement. You need to remember or know about the toxicity or the toxicokinetics of the chemical and the metabolism in the matrix that you're going to be looking at, and some sampling factors. And I'm going to be giving some examples about what I mean by each one of these considerations. First and foremost, make sure that you select the adequate biomarker. And I'm using here the example of diisononyl phthalate. This is a phthalate used as a plasticizer, and then it metabolizes in many different metabolites. In our methods at CDC, we have two metabolites. One that is a minor metabolite, about only 2% of the dose of the parent compound, and another metabolite which is about 11% of the dose. Why is this important? These are NHANES data in which we measure the concentrations of the minor metabolite and the major, not major, but one of the major metabolites. This, unfortunately, is one of the examples of the chemicals that are metabolized in many different things, so it's hard to track exposure to them, so you need to you cannot measure every single metabolite, you have to select a few of them. So these are the only two we have. So what is interesting here is, in NHANES samples, only about 13% of people had detectable levels of the minor metabolite. If we are only measuring that metabolite, I'm going to say that prevalence of exposure to this chemical is not that huge. However, they were 82% of people who had non-detectable concentrations of the minor metabolite, yet they had detectable concentrations of the major, or one of the major metabolites. What does this mean? That we would have classified as non-exposed about 82% of people in the sample. So it is really very important that you select the most sensitive biomarker of exposure. This is not to say that this is not a useful biomarker, but maybe in occupational settings where exposures are larger, then that may be better. But under general background exposures, this may not be the best biomarker. Collection protocols and data interpretation are also very important. And then if we think about collection of samples in a place which is convenient, like a clinical setting, maybe at the time, if we're thinking about birth cohorts, then at the time the woman goes to deliver the baby, or maybe if it's something that we would be interested in, like breast cancer, at the time of some surgery, IVF treatments, you name it. In these situations, then you're using, or the doctor is using a few devices on you, and then these devices, they may contain plasticizers. Like DHP, this is one phthalate, the only one, to my knowledge, with FDA approval to be used in medical devices, or BPA, and these compounds could leach from the tubing. You could also have antimicrobials or preservatives like parabens that then may be used in some of these alcohol-free wipes. So turn around and see if the alcohol-free wipe doesn't mean it's chemical-free. Maybe you look in the back and it's going to have preservatives. Maybe it has some parabens because there has to be something that preserves that moist paper inside, like a little pouch. So what I'm trying to say here is that in these situations, and you're collecting a sample and you're analyzing it for a particular chemical, DHP, BPA, parabens, for example, the data that you're getting are going to reflect a true exposure, but this exposure is not really reflective of a pregnancy, for example. It's just the reflection of an intervention that the woman had in the hospital. We talked this morning with several of you about variability in concentrations. Non-persistent chemicals are excreted in urine, and then the concentrations tend to be variable. And this is a busy slide, but I just want you to look on the right side at this going up and down. These are 7 days, 8 participants, and then 7 days, and each one of them provided every urine void during these 7 days. These, by the way, are CDC employees, very dedicated, 8 dedicated CDC employees. And then that you can see is that depending on the chemical, this is monoethyl phthalate, is the metabolite of a chemical used in personal care products. And this is MEHHP, is the metabolite of DHP, the plasticizer, for which exposure happens mainly through diet. So what you can see is with the personal care product chemical, you see concentrations going up and down for every, this one is overwhelmingly so, but this is a good example. Concentrations go up and down. And the same thing with the compound that is coming from diet. Concentrations go up and down. What does this mean? It means that you have a short-lived compound and exposures that are episodic in nature. So you're exposed to a chemical because you're eating food that was contaminated with this chemical. You eat today, you eat tomorrow, but you probably are not eating the same thing every day. You're using a product, so that product you may use it, personal care products, you may use them at one particular time every day, in the morning, in the evening, whatever, but there's going to be a pattern of exposure, but the urine sample is important that you collect them, you know, at the peak, if at all possible, but those are going to be very difficult to catch. So this exposure is going to be unavoidable. I mean, this pattern is unavoidable when you have episodic exposures and short-lived chemicals. So can we really use only one sample to assess exposure? If I sample this person here, I'm talking about a concentration that is actually almost 2 parts per million. Versus this same person, just earlier in the day, the concentration was maybe 100 parts per billion. So can one sample represent exposure? And then the answer, at least in my opinion, is that is yes for an average, the average for a population, probably not for a person. But then it's really important to remember that probably to get the best exposure assessment, you will have to collect more than one sample, not only one. And variability, unfortunately, or fortunately, I mean, I guess, is in urine, but is also in other matrices. So if a chemical is non-persistent, concentrations are going to be variable in urine, are going to be variable in serum. And this is just an example of dietary exposure from BPA. And what you can see is in the green circles are serum measurements that this was collected on pretty much on one day. And then the black triangles are urine. And what you can see is that each one kind of tracks the other. So, I mean, not unexpectedly, I would say, the concentrations peak earlier in blood, and then they just go into the urine. That kind of, you know, that variable, I mean, they follow the same pattern. It's just that there is about a 1 hour time lag between the elimination in urine versus the serum, and the concentrations in urine are overwhelmingly higher than the concentrations in serum. So what does this mean for exposure assessment? It means that if we collect one sample, can I say that this sample is useful to categorize exposure to chemical A for this person? And this is going to be variable depending on the biomarker. So when you're collecting a sample, you may be measuring different biomarkers. That answer may be better for one chemical than another, and this is going to depend on the type of exposure, it's going to depend on the population, it's going to depend on the half-life of the chemical. So for chronic exposures, I think one sample is pretty good. I mean, if you're getting something like, you know, you think about levels of oxygen in your blood, they're pretty much stable, even though, you know, like it's something that would go very quickly, but it just happens all the time. For episodic exposures, the one sample may or may not be adequate, and it's going to depend on the type of exposure, whether it's diet, whether it's use of products. Again, what we said at the very beginning, the frequency, the magnitude of exposure, and the population. Maybe for a child that has a certain pattern of activity, one sample may be representative of exposure, but is not going to be for an adult that may have a much more varied, and diverse type of activity. Can we overcome this variability? And I think that the short answer is no, but we can try to do different things to just kind of mitigate, if you want, this variability by collecting multiple samples. And then, but this can pose some questions about the cost, storing the samples, the analysis, and also compliance. You know, like maybe you're asking a participant, and I said, I want, believe me, the 8 dedicated CDC employees at the end of the week were pretty tired about having to have given all those urine samples. And these are people who live by, by biomonitoring, that they would, so at the end of the day, you say, okay, 1 week was enough. So how much can you ask a participant? So one of the strategies that I have been proposing to several people is the pooling of several spot samples. So collect several samples from a person within a time period, and then pool them together. So that would give you kind of like the average exposure that I hope I'm going to show you with NHANES, that it does really work. The other issue is that, as said already, the concentrations in blood are much lower than the concentrations in urine, and this put an additional if you want, push for having very, very sensitive methods, because a method that may work in urine may not work for having enough detects in blood because the levels are just so much lower. However, despite this variability, I still think that when the exposure is the overwhelming factor, even one sample is enough, and you don't need to have thousands of participants. This is a study that we did a few years ago with Karen Michaels at Harvard. These are 75 Harvard students that is also going with the work that Katherine is going to be doing. And then they consume fresh soup for a week or canned soup for a week. Again, these are 75 people. This is one sample, one sample. The levels, I mean, I don't think I have to convince anyone that if you have canned soup, the concentrations of BPA are going to be higher than if you have fresh soup. So regardless of variability, it doesn't really matter. And this is another example that regardless of variability, you still see with one sample what can happen when you use products that contain certain chemicals. These are different populations, and also look at the numbers. We only had 19 pregnant women here. Over here we had 406 men. So are different studies in which what we were looking at the number of personal care products a person used, and at the concentrations in their urine of the metabolite of diethyl phthalate. The compound that I showed you, the concentrations go up and down, and did you see how much they were going up and down? Well, we did not analyze the products for phthalate content. They may or may have not had phthalates. We didn't analyze. I mean, that was a huge criticism by industry for the papers. But anyway, what you can see is a very nice dose response if you want. The larger the number of products you use, the higher are the concentrations of the chemical that is present in personal care products. Again, despite variability. So, to interpret biomonitoring data, need to consider metabolism and the other toxicokinetic data. Remember, we measure concentration, not exposures. And then we need to select the most representative biomarker. When is this important when we're comparing exposure among different chemicals? Because again, we're looking at concentrations, we're not looking at exposures. We know that sampling may affect the concentrations. I didn't have time or today to cover what could happen when your matrix may have been, there may be cross-contamination, collecting urine from a baby, that they may be a soiled diaper. So then are you really measuring what was in the urine or what was in the feces, what was in both and what was in the diaper? So these are considerations that we need to keep in mind. And then the contamination, because in many cases we're measuring chemicals that are pervasive in the environment. The concentrations are so much higher. So if these chemicals are in dust, if the chemicals are in air, these chemicals are going to get in the lab as well. The lab is as, we try to have clean rooms, but still, there's people going in there, and then the chemicals are going to be in there. So, not all analytes are exposure biomarkers. Many analytes can be measured. As a chemist, I'm supposed to measure anything. I mean, and I was saying today, the more chemicals you measure, it seems that you're a better chemist. So you can measure many analytes, but you need additional information to determine whether these measurements really correspond to exposure biomarkers or are good biomarkers. So after we have done all of this, then what do we do with all this? What do we do with all this biomonitoring? Well, we really want to evaluate human exposure to chemicals, and then we do so at CDC, by looking at large surveys, and NHANES is the largest one, the one I'm going to be talking about. And then some epidemiological studies with a specific population, which actually are some of the ones that I draw the most pleasure out of it, because they help us answer some questions that NHANES doesn't have answers for. We also do it, in some cases, emergency investigations and disease clusters, but I'm not going to be covering these ones today. So NHANES, for those of you who don't know, stands for the National Health and Nutrition Examination Survey. Is a survey annual since 1999 and is conducted by the National Center for Health Statistics that is based in Bethesda, and we get money from Congress, so you all are paying for NHANES, and is mainly focused on obtaining clinical and nutritional data. Is a very complex survey. After all, is being done by our friends, our colleagues in our sister agency, statisticians, and then it samples the U.S. population. We are about more than 300 million people, but then it samples about 10,000. The surveys are in 2-year cycles, so every year is about 5,000 persons, 15 counties in the United States, and these are the mobile examination centers where the exams of the participants take place, where they provide the urine and the blood samples. The is a very data-rich survey because the participants get a physical examination, then we have collection of medical history, some dietary information, behavioral information. I mean, it's really a truly magnificent survey, in my opinion. And for us, what is important is also collects biological specimens, which are mainly used, and this is, I think I may answer some people's question about why don't you measure it in everybody? Most of the blood and urine are used for clinical and chemistry tests, so we just have to work with the leftovers. There's only that much, I mean, particularly blood you can get from certain individuals. So that's why we do biomonitoring in NHANES, because we have limited amount of blood particularly, and the collection of the urine, although this is going to be changing soon, starts at participants 6 years of age and above. So we only have urinary measurements for people 6 years of age and above. We're going to get data from the 3 to 5 very soon. Unfortunately, we're not going to be able to go into the youngest one because that would be very difficult to collect from kids that are certainly not potty trained at all. In the blood, they collect a blood tube from the little ones, and then it goes up to close to 10 tubes. I mean, it's spread out differently, but that's actually logistics. We had to, a few years ago, had to think about how do we do this, because apparently people don't care that much about the amount of blood that you take, but about the tubes. So I can get 500 mils on one tube, but I cannot get 50 on 10 tubes. So this is something I didn't know, but I know now. So we measured the non-persistent chemicals in urine and the persistent chemicals in blood, and also everyone in NHANES, 1 year of age and above. We do lead, cadmium, and mercury in blood, and cotinine in serum. And then although the sample would be about 10,000 participants, then they're randomized in subsets of participants, which are about 2,500 persons per chemical for each year of the survey cycle. So we, except for lead, cadmium, and mercury that everybody gets measured, that has the samples analyzed for, cotinine for 3 years and above. For all the other chemicals, the average subset is about 2,500 people, yet still representative of the US population. With the data, what we do is, in our center, in my center, is the National Center for Environmental Health, so we're not the statisticians, we have a few of them, but we're mostly chemists. We put this National Report on Human Exposure to Environmental Chemicals that is posted on the website now because it has just grown too large to just have it on paper. And then we can use this data, and I'm going to give you some examples, to set reference ranges, to track trends, to monitor the efficacy of interventions, to assist with certain priorities, and then to be used for exposure and risk assessment. This is reference ranges. This is benzophenone 3. This is a sunscreen agent, and this is data from 2003-2004. The slide has a lot of information, but I just want you to pay attention to these dark bars. And just these are the concentrations of the benzophenone in urine by age and by race. So Mexican Americans and non-Hispanics and whites. And sunscreen, you know, like it goes without saying that if you think about it, people with lighter skin is going to tend to use more of the sunscreen agent. Yet everybody has some. But then if you look at the trends that we're seeing by age, again, this is Antonia's interpretation, so no scientific proof, but I'm just going to say it anyway. You see a decrease in concentrations with age, starting from the younger kids to the older ones, which kind of makes sense to me. The younger kids, the parents want to just protect the children from the harm from the sun, so you make sure that you get them very well sprayed and very well just all over. As the kids get older and they don't want to, get away from me. So, and also they want to get tan, so they don't care about using sunscreen. They're just going to go. What happened in adulthood? In your 20s, boy, you want to look good. So I'm just going to put that sunscreen because I don't want to be burned. I'm going to go to my party, whatever. Okay, so you use sunscreen. In your 30s, it goes down because you're putting the sunscreen on your children and you don't have time to put it on yourself. It gets to your 40s and oh my God, all these wrinkles are coming up and then I have to do something about it. After 50, you know there's no hope. The damage is done, so why do I need to care about it? Again, I have said it several times because to me, science always makes sense, and this is a way that I think, despite the fact that is variability, despite the fact that is a one sample, it just makes a lot of sense to me to explain what you really see. We can also use enhanced data to establish the prevalence about certain thresholds, and of the many chemicals that we measure, and there are around now, I think is about 300 of them, there are only very few that have a clear health effect, lead being one of them. And actually, enhanced participants only get blood lead, cadmium, and mercury as a result on the environmental chemicals that have been measured, nothing else. But so the lead, the blood lead level had been set in the 2012 and was based on the 97.5, I don't know how you would say that, percentile of blood lead in the United States. And this reference value will be reevaluated every 4 years with the most recent data set of NHANES. Because although we have made tremendous progress in showing a decreasing concentration of blood lead, still in certain areas like the inner city and some minority children, then they may just have still higher exposure to lead than other segments of the population. We can also use enhanced to assist in risk assessment. And triclosan is an antibacterial agent, which is one chemical that is actually regulated by 2 agencies. FDA regulates it as a chemical, as a drug used in personal care products, and EPA is a pesticide. It was first registered as a pesticide in 1969, and in 2008, EPA used our enhanced data actually to determine that it was safe to continue using triclosan in the products that they have it approved for, because the biomonitoring data that we had, that again, it doesn't have data for children younger than 6 years of age. It was when they calculated exposure and then they just went back to the dose, this was below the doses that would cause harm in animals. And part of their reasoning for using enhanced data was that it was triclosan specific. We are only measuring triclosan, nothing else. It was based on the actual consumer use of triclosan, of people using triclosan containing products. So again, biomonitoring integrates all sources and routes of exposure, so whatever we're measuring in that urine sample comes from everything that the person used for triclosan, and that had triclosan as an inclusive of all triclosan related exposure, either as a pesticide or as a drug regulated by FDA. We can also use enhanced to monitor trends, and I have been talking so far mainly about non-persistent chemicals, and I'm just going to give you a flavor of some of the persistent chemicals. These are fluorinated surfactants that had been used, like PFOS was a surfactant used in Scotchgard. So 3M in 2002 stopped its chemistry, I don't know how many $1 billion chemistry, they just stopped production of the precursors of PFOS. This is what you can see, the production of the precursors had increased dramatically in the late 1990s and then just plummeted in 2002. I don't have other data from later that goes down, but what is interesting here is that since 1999, when we first measured the concentration of these chemicals in NHANES, the concentrations of PFOS have gone down by 68%. So you see that decreasing concentration on the median level, and you see a decreasing concentrations at the 95th percentile as well. So you stop the source, you stop exposure, which for a public health agency as ours, then you want to prevent harm, prevent the exposure from happening, and then there's going to be no harm. But then when you take a chemical out, you put a chemical in. So this is an example with pesticides, and it's again a similar one. We don't have as many cycles because there was a break in between, but this TCPY is a metabolite of chlorpyrifos. It was an organophosphate pesticide, insecticide, and was banned in use, residential use, in the early 2000s. Then TCPY concentrations are going down, and the concentrations of 3-PBA, which is a non-specific metabolite of pyrethroid insecticides, seem to be going up. So we're moving from organophosphate insecticides, concentrations go down, and at the same time, I like this slide because then it shows you that the concentrations of the other are kind of going up. So you take a compound out, another one is going to come and take its place. And this is another example in trends with phthalates. And it seems again that some concentrations appear to be going up, and this is the metabolite of diisobutyl phthalate, and the one that seems to be going down is the metabolite of dibutyl phthalate. On the other side, we had the concentrations of a metabolite of diisononyl phthalate, the first one that I showed you, that had the non-specific, but the minor metabolite than the other. And this is the concentration of one of the metabolites of DHP, another plasticizer. So 2 plasticizers, 2 compounds used more like as performance chemicals in lacquers, in inks, and something like this. The parent compound here has been banned from use. The same thing with the DHP has been banned from use. So concentrations seem to be going down, and by the way, it was banned in 708. In 2008 legislation took place. And the concentrations of the others appear to be going up, the replacement. So you take one out and you put another one in. And why do we think some of these, we see these trends? In this case, we can attribute to legislative actions, the same way that for the pesticides we did. But also, I think, is public scrutiny and public, getting more involved and concerned about their environment and just thinking, I may just want to be used products which are phthalate-free, for example. So, NHANES shows, I think, a bunch of different things. Widespread exposure to a large number of chemicals. They have multiple sources and exposures that we only with biomonitoring data we cannot pinpoint. We have difference in prevalence and magnitude of exposure among demographic groups. I don't know what I did. And, well, I killed it. Or maybe this. Okay, I knew it. You cannot give me one of these. I just go, thank you. So, and then you have sex and race-related differences, and socioeconomic differences, which I didn't show, but for example, triclosan, the antibacterial agent, the antimicrobial agent that is used in soaps, in dishwashing liquids, in Colgate Total, is the only toothpaste I know that has triclosan. In NHANES data suggests that the concentrations, the exposures are higher, the higher the income, which kind of makes sense. They tend to be more concerned about the chemicals. They don't want chemicals in the environment, and then also have the economic power to pay more for the product, because antibacterial products are more expensive than the others. In the reports that we put the data in, we have very limited data interpretation and no health outcome analysis. If anything, then we have our famous disclaimer that the presence of a chemical in the body doesn't mean it causes disease. We don't identify the levels that may be related to disease. We need additional studies. And per design, NHANES is a national survey. So it doesn't have geographical location, although you can get some information from the research center. It has no seasonal data, which is a problem when you're looking at something like pesticides, for example. And then, if I may just be getting information about pesticides at the time when they're not applying them in the field, versus it would be important or interesting to know whether we could get this information. And all of this is for privacy and concerns. So remember I said they go to about 15 locations in the United States. And then, so there are 15 locations that you know where they're going, and if it's someone who has some particular occupation, you know when that person went for the exam, and they give you the date, the time that the sample, the date that the sample was collected. Somebody could go and try to figure out who was the person. So in order to protect privacy of all the participants, then some information is a no-no. And then, so we need, and then one of the major problems with NHANES, or drawbacks with NHANES, is that we have limited biomonitoring information on the young, so we need to work on some other studies to answer these questions. So I'm going to move through this quickly because I talk a lot and I see that I'm taking a lot of time. But that was one example that we did a few years ago, actually, that we published it in 2004. It's amazing that this was 11 years ago. That was the first time that we identified a medication as a source of exposure to phthalates. So that was a study that we are still ongoing in collaboration with Russ Hauser at Harvard, and was a study for looking at exposure to phthalates and semen quality. And then one of the samples in one of the batches had a concentration, this is creatinine corrected, without correction I think it was like 17,000, so this is 17 parts per million, I mean huge, one of the highest concentrations we have seen. I called Ross, I said something is wrong, we have a problem, I don't know what this is, but we have run the sample, I don't know how many times we keep on getting the same result. Well, it turned out that this person was someone who had colitis, some type of, and was taking 12 pills every day for 3 months. And it turned out that it was called Asacol, that's the name of the medication, and one of the inactive ingredients, it doesn't have to be listed, remember, in the products, it was dibutyl phthalate. And what we were looking was at the monobutyl phthalate. The concentrations were so high that they approached the norm in animal studies. So we went further and we used NHANES to see, can we really confirm that this is a source of exposure? Again, remember variability, 6 people and about 8,000. And what we saw was that, again, the exposure is so overwhelming that even in these people, the mean levels of the phthalate metabolite were so much higher than the levels of the others that were, you know, unremarkable. They were what we normally see in the general population. So again, confirming our initial study, and interestingly enough, one of these 6 persons was a pregnant woman. But what actually, if public health works, and you think that intervention matters, so this is one of my favorite slides because it shows that since 2010, the maker of this medication has put cautionary language just on the labels regarding the use of this medication during pregnancy and lactation. And there is another medication, Pentasa, that has the same active ingredient, but no phthalates on the coating. So you could get the same care without being exposed to the phthalate. So this to me is, again, may cause fetal harm based on animal data for dibutyl phthalate, which is an inactive ingredient in this coating. So, you know, at least now we know about this. This is one that, another study that we did a long time ago, actually a series of studies we did years ago, in which we were very interested in looking at exposure to neonates in the NICU. You know, these are premature children, they're children obviously with many medical problems, but they live in a plastic world. So they had been postulated, so to speak, that exposure to certain chemicals in that plastic was much higher than in other persons in the United States. So we actually, in one study, we recruited, or our collaborator recruited 6 very little kids. And then they were pretty sick and doing with a lot of interventions. And then collected multiple samples from these kids. And then what we saw were the concentrations of one of the metabolites of the plasticizer, DHP, were so much higher than the concentrations that we were seeing in the general US population, from 4 to 130. We did an additional study looking at other children that then we categorized based on the interventions that they were having as having low exposure, medium exposure, or high exposure. And although we didn't reach, I mean, although it's probably very similar, you can see that the lower, the higher you think the exposure is, the data that we were finding in the urine of these kids confirmed it. So as a result of this, in many cases, and there are many hospitals now in the US that have moved from doing DHP products or medical products to other type of medical devices that do not have this phthalate. So I'm not saying that, you know, and again, one has to think about what are the benefits of the treatment versus what are the potential adverse health effects. As a mother, if my child was in the ICU and you say it's going to be exposed to phthalates, I said, I don't care, just I want my baby. So, but I'm just trying to say that there are alternatives that wouldn't expose the baby, which already is pretty vulnerable, and that's why it's in the hospital for treatment, to some chemicals that may cause additional harm. This was a follow-up of the study, and we also looked, in addition to that was the study that we classified low, medium, and high DHP, and we looked at BPA. And again, that was one of the first time that we saw that medical interventions could result in a higher exposure to BPA. The geometric mean was around 30 parts per billion, while in NHANES is around 3.6, so we're talking 10 times higher. And the concentrations of BPA and the metabolites of DHP increased with exposure, and again, as a result of the medical intervention. So there has been a lot of talk about when is the critical window of exposure, when are exposures, when do they have the potential to do the most harm. So is it really true that the first 9 months are the ones that shape the rest of your life? So it's really, in children's health, it's very important that we consider, does it really matter what happens before even you're born? And if you think this is the circle of life, so to speak, that my mentor, Larry Needham, some of you may have known him, put together, and then we had NHANES in urine, 6 years and above, 12 years and above, here we're going to death, and then, but conception, and then just goes, and then all this period, we were hardly covering it. I mean, certainly not with NHANES. So it's really important that we look at this population. So that's why we need to collaborate with people like you. And it's also very important to think about the studies that are going to address not a gross malformation, because these chemicals may not cause, like something huge, but there's going to be maybe a small change that on a population, on a personal level may not make a difference, but on a population level, maybe, like a small change in IQ may not be critical for that person in particular, but on a whole population, that could be certainly important. So look at developmental versus chronic effects, and then, the important work of epigenetics. So these are just some of the examples, and this is one that we did years ago with Shanna Swan. And then it was the first one that actually brought attention to looking at these subtle changes. And what Shanna did was very clever, and then we were looking at exposure to phthalates and then anogenital distance. Males have longer anogenital distance than females. So what was interesting is after creating a phthalate score based on the concentrations of the different phthalates that we measure in the urine of the mom, then it seemed that, like the higher the score, the shorter was the anogenital distance in boys. So the boys became more feminine, so to speak. So this was also prompted attention and a lot of media coverage and industry backlash. So about, like why do we look at it? But again, to me, it's a seminal work because it looked at a subtle change, which is something that I see environmental epi just moving more now in the future. Since then, we have been doing studies with many people, and then there is a lot of wording in here, but what I'm trying to say is that these chemicals can affect pretty much any system in our bodies. So we can start by just looking at body size or body weight at birth, and then just find out whether this is something that may be important, because like it may just position these babies at a higher harm later in life. And the most important thing is exposure to many of these chemicals can be avoided if we knew where these chemicals are used, if we knew where these chemicals are present. And in some cases, because these are the so-called inactive ingredients, then they don't need to be labeled. You don't need to know. You only know about the active ones. And this is one that we were looking at now. A lot of people are looking into childhood behavior, so behavior as one of the endpoints being looked for as being modified by exposure to some of these compounds. BPA and phthalates are just an example. And these are just some of the works that we have done with the different birth cohorts here in the United States. We also can use biomonitoring in animal studies, so to improve the dose response. And this was a study that we did years ago with Sue Fenton when she was at EPA. She's now at NIHS. And then looking at the concentrations of one other surfactant, PFOA, in some animals. And then just to see, based on the concentration that you had given to the animals, so the control had very little, and then all the others, like you can really make sure what got into the body of the animal rather than going by the administered dose. So if I'm finishing now with some, what I say, the take-home messages, biomonitoring is only one tool, integrates all the sources and routes of exposure. You measure very low concentrations versus what is in the environment, and expensive, requires complex analytical methods, trained staff, facilities, and so you name it. Many analytes can be measured, but not all of them are good exposure biomarkers. So make sure that if you do biomonitoring studies that you select the appropriate biomarkers, and for that you need to, may not know, but you need to make sure that you consult a toxicologist, and then they can tell you, this is how the metabolism of this chemical goes. You may need multiple samplings, and you need to know how, when, and where were the samples collected, because that may impact the results that you're getting. But in my opinion, when you use it properly, biomonitoring improves exposure assessment. In case of NHANES, I hope that I told you, or I convinced you that NHANES is an important tool, that it provides very valuable information that is publicly available. I mean, we put the data on the website, anyone can use the data. Not only the US taxpayers, but anyone in the world, as long as they have an internet connection. Per design, NHANES doesn't answer all the questions, so that's why we need to do some of the other studies. And what do I think we need to keep on doing? So certainly we need to continue with NHANES, but we need to not to stop in NHANES and conduct these additional studies that may look at these vulnerable populations, at highly exposed populations, that sometimes you think about highly exposed as someone who's in occupational setting, and doesn't need to be in an occupational setting. But you may be able to find some of these highly exposed population from a particular just something that you have done in your daily activities, and they may be very useful to just determine whether these compounds have adverse health effects, and also to use internal dose in animal studies. I said when we started that I'm speaking for many people. We are a division of about 400, and it's without the work of everyone, I wouldn't be able to be here. It's a true honor to represent the Division of Laboratory Sciences, my collaborators at the National Center for Health Statistics, and my beloved collaborators who are everywhere in the United States and abroad with whom I just enjoy the collaborations and learning from them. And I want to thank you all for your attention, and hopefully we have time for questions. Thank you.